Having been involved in drug development for about 30 years, you get a couple of learnings along the way. A few decades ago, I was working on a medication for ALS and had the opportunity of working with the folks over at Columbia. So I met, some of you may remember Hiroshi Matsumoto, who led the Lou Gehrig Center there. And I went in and talked to him about our study. And he said, Randall, before you get started, don't sell me on your drug. At Columbia or in our clinic, we as part of our treatment paradigm, we enroll all of our patients in some form of clinical research. And so it's not a matter of if they'll be involved in research, but more of a matter of which study they'll be involved in. So tell me a little bit about your medication, and then tell me a little bit about your study, and then we'll kind of see where it goes from there. So that's what I'd actually like to do with you today is do more of sort of a cursory review, see if we can get you interested in the approach that we're taking, look at the study that we're involved in, and then we'll see. We're working on LP352. Its proposed mechanism of action is a 5HT2c agonist. There's a lot we already kind of know about this from a mechanism of action standpoint. You think about if you take a knockout mice, you knock out that receptor, they spontaneously seize. We know from the Dravet syndrome model using mutant zebrafish, we know that 5HT2c agonists seem to decrease that seizure-like activity. So, and then we also know just from a clinical standpoint that there are compounds out there that seem to interact with this receptor and interact in a way that have a sort of proven concept, where we're thinking of fenfluramine, Fintepla, or lacostrine. So what we proposed is to focus on more extreme selectivity, is focus on the 5HT2c receptor, as known as putatively the part that would be contributing most to efficacy, and doing our best from chemistry standpoint to remove any agonism at B and at C and at A, because it's generally felt that those are contributing to the negative adverse events consequences. So presenting to you 352, we have done the zebrafish model. And what we've learned is if you're looking at duration of epileptiform of events, LP352 demonstrates an 85% reduction in the mean cumulative duration of these events. And we also know it demonstrates an 84% reduction in epileptiform frequency. So we know it's interacting with the receptor. We know that it would have a promise potentially of a favorable clinical result. We've also, in a SAD/MAD study, looked at a certain biomarker using prolactin for central 5HT2c activity, and we saw at the lower levels of dosing, not much interaction, not much increase in prolactin levels, and then increasing in that 6-12 to range, and then sort of maxing out. So it tells us that we are getting that interaction. The prolactin levels went up, and that increase was transient, and certainly not at the levels that would make one thinking about the adverse events of prolactinemia, but this is more from a biomarker standpoint. What we also learned in our SAD/MAD PK studies is LP352 was rapidly absorbed, no appreciable food effect. The Tmax was quick, between an hour and 2 hours. As you would imagine, most subjects were at steady state after 10 days, because the half-life was relatively short in that 5-hour range. And then we also learned that 352 was eliminated by metabolism through our in the SAD/MAD cohorts. So the compound performed as we'd expect from a SAD/MAD standpoint, but also from a safety standpoint. We learned there were no clinical differences in the fasted and fed cohorts in terms of any of the blood chemistries, no significant mean changes from a cardiovascular standpoint in terms of cardiac troponin levels, ECG parameters, mean changes in baseline vital signs, not considered clinically significant. And then finally, we did see one serious adverse event, Interestingly, this was observed after discontinuation of therapy. In fact, it occurred 2 days after abrupt discontinuation. High degree of anxiety in one of the subjects, and it looked and appeared very consistent with serotonin related discontinuation or withdrawal syndrome. So it tells us as we get into the clinic, it's going to be important, like we do with SSRIs, is that a taper would be critically important to do both on the way up and on the way down in when patients are coming off therapy. So lastly, I'll just take you through our study design. This is our Pacific trial design, our 1B2A. We start with the screening period for the first 5 weeks. During that screening period, we are looking historically, the patients have at least 4 episodes of countable motor seizures or more, and then during that baseline, historically for the past 3 months, and then during that baseline period is to count the numbers and needing to have a minimum of 4 during that baseline period. They then move into a randomization and up titration. So they start off on placebo, 10 subjects, or on LP352, 40 subjects starting off at 6. If tolerated, they can go up to 9. If tolerated, they can go to 12. They can titrate up and down purely based on tolerability. At day 15, they're locked in. They stay on a maintenance period for 60 days. At the end of that treatment period, there's a down titration that we describe based on the SAD/MAD data. Overall, we're planning on 25 sites, although it's likely we'll go up a little bit higher in terms of the number of sites. The slide demonstrates the age group of 18 to 65. However, we're in discussions with FDA to lower that age group into the adolescent population. We expect to have that completed for enrollment sometime this summer. The key inclusion criteria, I'm sure you're kind of wondering, is when we talk about developmental and epileptic encephalopathies, many of the presentations that you've heard today focus on one of the syndromal ones like Lennox-Gastaut or Dravet. And while the syndromal ones are included, we're also including all the non-syndromal developmental DEs as well. So that opens it up to a larger group. Some might describe this as a basket study, giving an opportunity to understand a more vast, larger group. Clearly for a 1B2A study, the primary endpoint is safety, tolerability, and PK, but it does give us the opportunity looking at some key efficacy signals, evaluate reduction in seizure frequency across a broad group of epilepsies, identify the potential indications that we could go into as we enter into our phase 2/3 program, analyze concentration responses to understand the dosing in different seizure types across the board. So it will allow us to have a little bit more insight into are we seeing responsiveness across the DEs, and does it matter which is the sort of phenotype that we're seeing in terms of their seizures? So we're excited to be embarking on this program. So I hope this gives you a sense of a little bit of a background on LP352, the study that we're involved in, and let's see if there's. I see some of you I know are involved in our clinical trial. I'm excited to see you here. Some, if not, if you are interested, we have the ability of bringing in some more study sites. So please ask. Thank you.